Hello, my name is Kia Chalk and I'll be talking about polycystic ovary syndrome. What is polycystic ovary syndrome? Polycystic ovary syndrome is characterized by two of the following conditions: oligoovulation or anovulation, hypoandroidism, and clinical signs and symptoms of that are polycystic ovaries. Etiology. The etiology of polycystic ovary syndrome is unknown. Some people like to say that it might possibly have to do with genetics. Obesity plays a factor. Also, exposure to androgens in utero. Polycystic ovary syndrome affects 6 to 15% of women at reproductive age, and it's the #1 cause of infertility. The pathophysiology of polycystic ovary syndrome. What causes this to happen? There is no single factor that causes polycystic ovary syndrome. An increase of the gonadotropin-releasing hormone and insulin resistance causes hyperinsulinemia and an increase of LH and FSH ratio. These two things combined cause an androgen excess in the body of the female. And it also causes decrease in follicle development. So the ovaries end up being polycystic, where they have, on the ultrasound strings, they look like strings of pearls. This also causes anovulation, so the woman does not have menstrual cycles because they're not releasing the eggs. Symptomology. Not having a period, hirsutism, which is hair growth, male pattern hair growth in a female, acne, infertility, obesity, alopecia, acanthosis nigricans, which is here on the picture, the darkening in the neck and under the arm areas, and miscarriages are all symptoms of polycystic ovary syndrome. Long-term effects of polycystic ovary syndrome include an increased risk for type 2 diabetes, cardiac disease, endometrial cancer, depression, bipolar, and binge eating disorder, and anxiety. Diagnosis for polycystic ovary syndrome. Diagnosis can be difficult because there's no standard diagnosis that's agreed upon by medical research. They use patient history of not having periods regularly, ultrasounds that show the string of pearls, like here in our picture here. These are all of the cysts in the ovaries in the picture there. Labs for impaired glucose testing and inappropriate gonadotropin secretions. Treatment for polycystic ovary syndrome. The #1 treatment is weight loss. That is the most important thing that a woman can do to treat the symptoms. Also, oral contraceptives, anti-androgens, which will reverse the effects of the excess of androgen, fertility agents, metformin, progesterone therapy, spironolactone to treat the hirsutism. My case study is an 18-year-old African-American female, Mrs. G, notices an increase of facial hair, mood swings, and irregular periods. She visits her OBGYN and had lab work done and an ultrasound. Mrs. G was diagnosed with polycystic ovary syndrome after lab tests showed increased androgen and ultrasound showed both ovaries were polycystic. Mrs. G was prescribed a diet and exercise and metformin. At the age of 21, Mrs. G conceived her first child. Mrs. G had no menstrual cycles for 6 to 1 year spans. Mrs. G was prescribed Clomid along with metformin to help her conceive another child. Over the next 10 years, Mrs. G had multiple miscarriages and gained weight to the effects of polycystic ovary syndrome. Finally, Mrs. G decided to use fertility treatments. She became pregnant with twins. Mrs. G was on bed rest for 30 weeks during the pregnancy due to complications. 4 years later, Mrs. G conceived naturally and had another child. At the age of 39, Mrs. G decided to take control of her weight and began a low-carb diet. She started exercising 4 to 5 times a day. Mrs. G lost 45 pounds and kept it off for 4 years. After the weight loss, Mrs. G's menstrual cycles are normal every month. She has no complaints of mood swings or Hirschism, and she is no longer taking any medications to treat polycystic ovary syndrome. Mrs. G is a textbook case. Textbook case here, Mrs. G has 3 of those things. The etiology was unknown. She was obese, and her niece was diagnosed 2 years ago, so there could be a genetic factor in the etiology. For pathophysiology, Mrs. G had polycystic ovaries. She wasn't having any periods. She also had decreased follicular development, which showed in her infertility, and an excess of androgen and estrogen. Mrs. G's symptomology was also textbook. She had the no periods, the acne, the overgrowth of hair, the infertility, multiple miscarriages, and obesity. Mrs. G was diagnosed based on her history, ultrasound with string of pearls, inappropriate gonadotropin secretions, and no periods. Mrs. G was treated by being told to lose weight. She was given fertility agents, Clomid, to conceive a child, and she was also put on metformin. The research that I found showed that insulin resistance is seen in 75% of lean and 95% of overweight to obese women. 1 unit increase in the BMI increases the risk of polycystic ovary disease by 9%. So a woman's weight plays a large part in polycystic ovary disease. Weight loss of greater than 5% of the body weight increases the chance of getting pregnant and the baby actually living in women with polycystic ovary disease. Weight loss of 3.5% decreases DNA damage and impact of cardiometabolic risk in women of polycystic ovary disease. So this means women with polycystic ovary disease, if they just lose a small amount of weight, it will decrease the chances of them getting diabetes or having heart issues based on polycystic ovary disease. Weight management is defined as prevention of excess weight gain, modest weight gain, or maintenance of a reduced weight through lifestyle, diet, physical activity. Behavioral interventions is a primary first-line treatment strategy in polycystic ovary syndrome recommended by evidence-based guidelines. Changes based on research. From the research that I found, the changes that I think that should be made is that the doctors should be paying attention to the patient as a whole. Mrs. G was told to lose weight. She was given medication, but she was not dealt with in the thoughts of her mind and her soul when it came to her having multiple miscarriages or a way of helping her lose the weight. Just telling an American, go lose weight, is not really going to help them. They're going to need support in order to not just do yo-yo dieting and lose weight here and there. They need to constantly be committed to losing weight, as well as women that are not overweight being able to maintain their weight when they're diagnosed with polycystic ovary disease, because polycystic ovary disease can cause obesity. So women are at a greater chance of gaining weight when they are diagnosed with this disease. So behavior modifications for weight loss, I think, would be an option. teaching them how to think about weight loss, how to every day make the decision to stay the proper weight or to lose weight, to regularly exercise. Also support groups for other women that have polycystic ovary disease, to talk to them about miscarriages, the loss of a child, and also the increased risk for depression. When you have multiple miscarriages, you know, you're gonna feel bad about it. Family planning, from the beginning of a woman being diagnosed with polycystic ovary disease, like Mrs. G, she was a teenager. So she had a whole lot of living to do, to get married, to decide what it is that her and her family wanted to do. Family planning for her and her husband, to make a decision on whether they wanted to have kids or the miscarriages were too much and they want to adopt. All of these things should be discussed by the provider. Also infertility counseling, when women start having infertility issues and starting the medication, they need to be counseled on the risk and the process that they're going to be going through. Grief counseling, again, for the multiple miscarriages, the changes in the women's body, those things all need to be addressed. And Mrs. G was a textbook case, but was she a success story for her primary care provider? I don't feel that Mrs. G was a success for her primary care provider because she ended up having to make the change on her own. When she was 18 years old, she should have been explained in detail what it meant for her gaining weight and what the effects it caused in her body, as well as setting up support for her so that she could maintain her weight at 18 instead of her having to wait until she's 39 and being fed up with her situation and making the change on her own. Her primary care provider should have had a moment and sat down with her and explained to her the risk, short-term and long-term, the increased risk for infertility, the issues with her periods and the hormones in her body, in order for her to be able to make a plan and set goals so that she wouldn't have to go through the multiple miscarriages as she did. So if I were Mrs. G's primary care provider, that would be the first thing I would want to set her up with, is counseling, to explain to her what's happening into her body and the effects it could have on her family so that she can make a plan to go forward. Thank you.